Good evening, everybody. First of all, thank you. I'm sure you must be so tired, but you're still here. So thank you all for being here. I'm going to talk about the importance of anti-Mullerian hormone in planning ovarian stimulation protocols. Today, since the last 10 years or so, anti-Mullerian hormone has gained a lot of importance, a lot of work has been done, and we are applying it more and more in our daily practice for stimulation and for assessing ovarian reserve. Ovarian stimulation with gonadotrophins induces an endocrine or a follicular reaction in the ovaries, which we today designate as an ovarian response. This ovarian response can be normal, there can be no response, there can be a poor response or a hyper response with the same amount of drug. There is a high intra and inter-individual variability. The response, of course, depends on the ovarian reserve, and the ovarian reserve is dependent on the age, more biological than chronological. So our aim, of course, is to achieve an appropriate stimulation with the agents that we use, and that would mean 1 follicle in ovulation induction, 2 to 3 in IUI, and about 8 to 10 in ART. So how do we do that? To assess then the ovarian reserve, which would help us to assess the ovarian response and thereby improve the efficacy of our stimulation protocols. Now, there are a number of tests to evaluate ovarian reserve, but today we know that the antral follicle count and the AMH remain the best indicators of ovarian reserve. The antral follicle count is measured, antral follicles are measured on cycle day 2, 3 or 4. All the follicles 2 to 10 millimeters are measured, and follicles under 5 designate a poor ovarian reserve. Follicles more than 15 would put the patient at very high risk for ovarian hyperstimulation. Now, AFC is very easy to count. The method is non-invasive, simple, accurate, but there is an intercycle variability in younger women. It is observer dependent, and there is a discrepancy in certain situations like post-chemotherapy, where you'll find that you're seeing antral follicles on the ultrasound, but the ovarian reserve is low as designated by the raised AMH and the raised FSH and the lowered AMH. So in that scenario, AMH came into the picture, which is a dimeric glycoprotein that belongs to the TGF-beta family. It is produced almost exclusively by the granulosa cells of the preantral and small antral follicles, and this morning Professor Hamburg very beautifully illustrated this and showed the staining in these granulosa cell of the preantral and small antral follicles. As the follicle grows and becomes FSH dependent in the ovulatory stage, the AMH is no longer expressed, and it's no longer expressed in atretic follicles also. So the role of AMH in follicular development is very important. It acts at 2 levels. One, at the primordial to primary stage, where it inhibits the recruitment into the primary group, and second, at the preantral stage, where it decreases the sensitivity of the preantral follicles to FSH, and thereby this is probably they say by the inhibition of aromatase activity, and thereby causes an arrest in this area, and it is thought to be the reason why we see the exaggerated AMH tone is thought to be the reason why we see this follicular arrest in PCOS. So when we look at the dynamics of AMH expression in folliculogenesis, it suggests that the basal AMH levels reflect the total developing follicular cohort. And therefore, if they do that, then they have a potential to tell us what the ovarian response to FSH is going to be. And so we can use them to do that and improve our stimulation protocols. We can individualize the dose of gonadotrophins, we can reduce our complications, we can offer appropriate counseling if we know how the response is going to be. And this allows us to improve efficacy, improve the safety and cost effectiveness of treatment. The AMH levels fluctuate very slightly in the menstrual cycle, so you can assess them on any day of the cycle. However, my recommendation is to do it in the early follicular phase between day 2 and 5, when you get really the most accurate values. There are variations in results due to sample instability. So if the sample is taken today and the assessment is done a week later and the sample hasn't been stored at -20, you may get altered results. We know that with age, ovarian reserve decreases, and AMH also decreases along with age, showing that the reserve is decreasing. Now let's look at the role of AMH in predicting ovarian response in comparison with our traditional markers, FSH, age, and BMI. Now Nelson in 2007 showed that AMH was the best predictor of oocyte yield as compared to FSH and BMI. In 2009, Nardo showed that AMH was highly significant and an independent predictor of ovarian response, and this was independent of age and PCOS. In this comparison, which was done between non-normal, poor, and high responders by Nelson, what he showed that for FSH, the values in normal and excessive responders is almost similar. But when you look at AMH, you find that it's significantly different in the poor and the hyper groups. So telling us that if we do an AMH assessment, right before we stimulate, we can know who is the person who's going to respond badly and who's the person who's going to give us a hyper response. So it is a better discriminator. Unfortunately, there is a slight overlay of values, especially in the low and the normal group between AMH. So this is very important to understand when we are counseling the patient, because if we have a normal value but veering a little towards the low side or a low value, and when we stimulate, the response may not be as expected. Where we are expecting a very poor response, they may respond normally, and a normal response may, where we think the person is going to respond in a normal manner, may respond in a poor manner because of this slight overlay of values. Now, Nardo also looked at AMH and AFC and FSH as predictions for extreme of response, and what he found was that AMH and AFC was significantly raised in the high responder group and decreased in the poor responder group. Compared with FSH and AFC, AMH performed better in the prediction of excessive response to stimulation, whereas for poor response, AMH was a better predictor than FSH, but not AFC. That means AMH and AFC predicted similarly the response, poor response, but in the hyper response, AMH was better. Now, we look at all these values are generally from the West, they're all Caucasian patients, so we decided to look at this in the Indian patient and see how the AMH fares in our patients in terms of response. These were all first IVF cycles that we took, and we used only an antagonistic protocol. FSH, AMH, and AFC was used, was measured on cycle day 2 and 3, and BMI was calculated. Patients were divided into 3 groups. Group 1 were poor responders, less than 5 oocytes recovered. Group 2 was normal responders between 5 and 14, and high responders were over 14, and they formed 5.7% of the group. Now what we saw was that the poor responders were older, significantly older than the normal and high responders. In BMI, there was absolutely no difference. In FSH, it was significantly higher in the poor responder or group 1 as compared to both the normal and the high responders. The AMH and AFC, both, if you look here, was significantly higher in high responders and significantly low in the poor responders. So AMH was definitely giving us a better picture in terms of what the response was going to be. And you can see here also the number of oocytes retrieved in the 3 groups significantly different, and the peak E2 levels, as expected, will be high in the high responder group. When you looked at the ROC curves, what we see here very clearly is that in the poor responder, at least in our patients, we found that for poor response, the AMH and the AFC, between the two, the AFC gave us a better picture or a better significance than AMH. But for high responders, both were equally good, and both fared in any case better than the FSH. You can see here the FSH curve and the AMH and AFC here. So in comparison to FSH, which was a traditional marker, AMH and AFC both were far better predictors of response. So we concluded that AMH is a better predictor of oocyte yield compared to FSH. In predicting poor response, AMH is superior to AFC, but not to FSH, but not to AFC. And for high response, AFC and AMH are equally good. The pregnancy outcome, which we took as a secondary measure, we realized that AMH could not predict pregnancy outcome. The p-value was not significant. The pregnancy rate in our group 1 was poor responders was 24.6, in the normal responders was 45.5, and in the group 3 it was 50%. But here the number of transfers we did was much lower because a lot of these patients, 10 out of 12 patients, had oocyte embryo freezing done electively to prevent ovarian hyperstimulation syndrome. Now, certain cutoff values have been suggested. For hyper response, a cutoff of more than 3.5 is suggested because beyond that you are going to have a very high risk of ovarian hyperstimulation. For poor response, a level below 1.26 detected poor responders with a sensitivity of 97%. That means they will get less than 4 oocytes. For very poor response, a value of 0.5 nanograms per mil would tell us that we'll recover less than 2 oocyte with a sensitivity of 88%. Normal response would be above 1.3 nanograms, and if the value is below 0.1 nanogram, then you can be quite sure that the patient is not going to respond to any kind of stimulation that you give. However, for poor response, as I told you earlier, because of the overlay of values, you must confirm it with the second line antral follicle count. The two together can give you a better prediction. Now, based on this, because we have so much information with AMH in terms of response, Yates looked at to see if you could tailor make our protocols based on the AMH values that we have, and he compared them to the conventional stimulation protocols which were based on FSH and chronological age. So what he did was patients below 0.3 nanograms were excluded or counseled for alternative methods like oocyte donation. Under 2.2 nanograms, starting dose was 300, and GnRH antagonist will use because this was going to be a poor responder group. In the normal response group, you could start with 200 recombinant FSH or 225 HMG, and you could go with an agonist cycle. And for the hyper responder group, the dose used would be 150 IU and an antagonist protocol. And with this, what they reported was that the embryo transfer rate was significantly increased. The pregnancy rate per cycle started was also significantly increased. The OHSS incidence fell. The cost of fertility drug treatment fell. The cost of management of OHS fell by 43%. So using AMH as a marker of ovarian response and guiding your protocols or basing your protocols on that level really helped to improve the effectivity of your treatment. Now, in our setup, because we believe that patients, the Western patients, respond much better, their reserves are much better. So we have devised our own system, and where we have an AMH of 0.1 to 1 nanograms per mil, age over 38, and antral follicle count less than 3, we counsel for IVF with donor egg or adoption. Where the values are between 0.2 and 1, which is still low, but the antral follicle count is above 5, we used to give letrozole. Now unfortunately it isn't allowed, with 375 international units of gonadotrophin, or if letrozole is not there, then 450 international units of gonadotrophin. Even in this group, we do not like to go with very high gonadotrophins, because at the end of the day, whatever you give, you are going to get only those 2-3 follicles or eggs which are there in the ovary. Between 1 and 3, an antral follicle count of over 10, we can do either an antagonist or agonist, and the dose we use is 300. Between 3 and 5, an AFC over 10 to 12, surely an antagonist protocol, and the dose dropped to 225, and over 5 with over 15 AFC, the antagonist with an agonist flare with cryopreservation of all embryos and using a dose of 150 gonadotrophins. The dose of gonadotrophin, of course, is going to vary based on the patient's BMI and the patient's age. So with this kind of a thing, you can see in all our groups, we have a fair number of oocytes, neither too much or not too little. So far as AMH for prediction of pregnancy, a lot of people have suggested that it is correlated to oocyte and can accurately give you live birth, a prediction of live birth. But overall, AMH testing has not appeared to be able to predict the probability of pregnancy after IVF treatment. The most important area which I feel it is important for is counseling. You know, when a patient comes into you, they've come with very high hopes that they are going to conceive and have a baby and go away, and they in fact put you under a lot of pressure by saying that they are here and you're definitely going to give them a baby. Now, two things. One is when the AMH is low and a young patient comes into you and she's, a few years into infertility and you need to decide what to do. So when you know the AMH level, you know how fast you're going to move with her treatment, how much time does she have before you go on to IVF or other forms of treatment. And when I'm saying counseling, it's not only for IVF, it's counseling for infertility treatment as such. If the AMH is good, you know the patient has time and you don't need to hurry or rush fast, and you can allow expected management if all other factors are normal for a little bit of time. Because if she conceives in that with normally, then she's saved all the expense and stress of IVF. If the reserve is very poor and the patient has to have IVF, you can't tell her that, look, your reserve is, AMH is low and sorry, there's no point. But what you can do is counsel her properly that your reserve, probably you will not get that many oocytes. However, you can try once. And if in that one trial, you find that the number of eggs you have retrieved is very low, the fertilization is poor, the quality of the eggs is low, then subsequently you are well placed to advise her for donor egg. So with that, I'd like to conclude that AMH tailored treatments allow us individualization and optimization of treatment, which lead to improved pregnancy rate and hopefully live birth rate. They decrease the complications, decrease the cost of treatment. They help us to counsel for alternative therapies, and this benefits the subfertile patients psychologically, physically, and financially. And with that, I'd like to thank you all for a patient listen.